All right. Well, welcome everyone to our March 22nd, 2024 Echo Dementia session. I'm going to share my screen here just for some preliminary slides. And hopefully you can see that okay. I've got an unusual kind of view. Well, I'm just going to trust that that looks okay. So just some basic reminders that we'll run through our kind of opening notes and general reminders. If this is your first time with us, we would absolutely love to meet you and would appreciate your info in the chat. And then we have the great good fortune of having our own Dr. Trang doing our extended didactic on pharmacological treatments for neuropsychiatric symptoms of dementia. This is such an important topic, and Trang is such an excellent provider and presenter that we did not do the usual push for a case this time in order to afford some more time, both for the didactic presentation and then a conversation, which absolutely, please do bring clinical vignettes or issues to that part of our meeting today. So just some general reminders. Go ahead and rename yourself if it shows up as a telephone number or something like that, just your first, last name and what clinic you're in. I think everybody has generally mastered the art of muting when not speaking. I still have to remind myself to say who I am when I unmute, and I haven't even done that yet, but I'm Chris Rhodes, neuropsychologist at UW. If you are able to turn your video on, that's always great, but understand that's not always possible. And it's less common these days, but if there is somebody else with you in attendance in your same room, please put their info in there too so we can keep track of CME. For all of our UW affiliated folks, here is the new process. And we'd love some feedback on this. I've tried it once and it seemed like it worked, and then I tried it again and it seemed like it didn't. But if you're a UW provider, you would text your info to that, your email address to that number. And then this is the number that specifies what CME activity it is. So Dementia Echo, and we'll post this at the end too. But maybe take a photo or a screenshot, or I think it's also in the info that Sammy sends out. Everybody else, we will keep track just by your attendance, and that's why we're asking for your info as well. A couple of other reminders for programs that you may find helpful in your clinical practice. So the TBI Behavioral Health Echo, Addictions Echo, Telebehavioral Health Training Series, also some telephone consultation for tricky chronic pain or acute pain issues, I guess, telepain also. The UW Psychiatry Grand Rounds is a treasure trove of didactic information, resources, handouts. The same for the Northwest Geriatric Workforce Enhancement Group. They've got such great resources online. And I'm sure you can find other wonderful things to do with your time versus staring at a screen. But boy, if you need info around a certain topic, these are great places to find it. We even though we don't have a case today for any kind of clinical vignettes or clinical issues, just a reminder to do your best, and we'll do our best to protect PHI. We do have all the recordings up on our website, which is reconfigured a little bit, I think a little more easily searchable. And then, of course, we will send out a 1-minute post-session survey as we continue to iterate this to make it the best possible program for this wonderful community. This is an overview of the last of what we would consider kind of the top 10 basic things that one should know as we try to take better care of our people living with dementia and their families. We are busily codifying the didactic schedule for the rest of the calendar year and would love your input. If you have a topic that you would like to hear about, either again or a new topic, if you have ideas for presenters, don't have to be local, it could be national or international. Happy to hear what would be most helpful for you all. We have ideas, but that's maybe not exactly what you need. So let us know. Cases, of course, always such an important part of our work that we do here. So reach out to Samantha or Nancy or me. We are accredited for CME, document disclosures. Here's our hub team. Here are all of you out around our great state of Washington. And with that, I'm going to turn it over to Dr. Trang Lee for our didactic today and leading our discussion afterwards around pharmacological treatments for neuropsychiatric symptoms of dementia. Trang, thank you again for doing this. And I'm going to stop sharing my screen. It's all you.
Thank you, Chris. Let me share my screen here. I have two of them, so let me see. Let's try this one. Let's do this. Can you see that?
That looks great. Perfect.
Thank you very much. Let me see a slide. Okay. All right. Great. Okay. It's working. Okay. Thank you very much. Thank you, everybody, for coming this afternoon. Today, I'm going to talk about pharmacological treatment for neuropsychiatric symptoms of dementia. It is a topic that I have heard so many about. Many of us have questions about, so hopefully today's reviews will answer some of your questions. So today we're going to discuss some of the drug therapies to manage behavioral and psychiatric symptoms of dementia. We're going to talk about use of antipsychotics, use of antidepressants, and also use of other pharmacologic therapies. And also we're going to discuss assessing the benefits of continuing therapy and the risk of side effects. So as we know that it is an estimated prevalence of about 50 million cases of dementia worldwide, and that number is anticipated to go up to 152 million people by 2050. So a lot of us will have dementia. And besides having cognitive and functional impairment, most of these patients with dementia will experience symptoms of mood and behavioral disturbances. So what are the neuropsychic symptoms of dementia? These are long words, so I'm just going to refer to the abbreviation NPS. So NPS stands for neuropsychiatric symptoms of dementia. So what are these symptoms? So they include psychotic symptoms such as psychosis, delusion, hallucinations, paranoia, sleep disturbances, and also disruptive behavior, including agitation, aggression, wandering, anxiety, depression, and apathy. One or more of these NPS symptoms observed in most of our dementia patients, about 60 to 90%. So a lot of these patients will experience at least one or more symptoms. The prevalence will increase with disease severity, and that leads to even greater functional and cognitive impairment, and it reduces the quality of life for both the patients and the care partners. And it can cause greater partner burden, depression, and employment difficulties. And then, of course, that will increase morbidity and mortality, and also healthcare costs. And we know that that can also accelerate to earlier nursing placement. Unfortunately, NPS are underreported by patients and family, so it is important for us to screen for NPS at a regular follow-up visits. So important questions for us to ask caregivers are, does a patient have any behaviors that worry you? Or does a patient have any hallucination or see things or hear voices that aren't there? So it is important for us to screen for that. We need to ask patients and family members. So how do we manage NPS? Non-pharmacologic therapies should be first line, but we also need to assess for any underlying causes that can increase these NPS symptoms, such as medication side effects, pain, delirium, depression, sleep problem, poor vision. If the patient needs glasses, and give the patient glasses. If the patient wears hearing aid, and give them the patient the hearing aid. Because sensory deficits can also increase agitation. We know that non-pharmacological interventions are first line. However, these interventions can be effective. However, the implementation is difficult because of limited resources, staff availability, and also training. So imagine if a patient can afford to hire a private caregiver, and that private caregiver would constantly distract the patient. Let's go walking. Let's do some painting. Let's do some drawing. Let's have some lunch. Let's take a break. Let's do some cards. By the end of 8 hours, that caregiver can be exhausted. And imagine there's no one-to-one ratio of patient and caregiver in an adult family home or in skilled nursing facilities. So therefore, even the pharmacological interventions can be effective. However, implementation of that can be difficult, and also achieving that may not be possible. So when non-pharmacological interventions fail, then drug therapy is recommended. So drug therapy is recommended when first-line therapy fails, and also when the symptoms are severe or distressing, or when imminent safety is a concern for the patients and those around them. So according to the up-to-date 2023 update on the advancement in the treatment of agitation in Alzheimer's disease, experts define agitation as one of the most common, complex, and distressing NPS resulting from a complex combination of neurologic, biologic, psychiatric, and environmental factors. So they think the proposed mechanism of agitations in Alzheimer's disease include just regulation of a lot of neurotransmitters, including serotonin, norepinephrine, glutamate, and other neurotransmitter disruptions. So therefore, medications are supposed to work through these pathways here, theoretically would be able to help decrease agitation or help with NPS symptoms. So what are some of the medications to manage these symptoms? Antipsychotics, a typical antipsychotics. I have 7 of them listed here. We can go through them. We also have antidepressants. We also have other drug therapies that I will go over all of them as well. So for antipsychotics, it's all second generation because we talk about outpatient use is second generation antipsychotics. A lot of them have off-label use. Some of them have FDA indication. So we have 5 of them that have off-label use for agitation, aggression, and psychosis associated with dementia. And these include olanzapine, risperidone, quetiapine, aripiprazole, which the brand name is Abilify, and clozapine. The ones that has FDA approval are the brexpiprazole, the brand name is Rexulti. That is the only antipsychotic that has an approval for agitation associated with dementia due to Alzheimer's disease. We have pimavanserin, which is Nuplazid, which is approved for Parkinson's disease psychosis. So how well do these antipsychotics work? So looking at the clinical trial that enroll patients with Alzheimer's disease, they enroll patients who to get olanzapine, quetiapine, risperidone, or placebo. They enroll patients with Alzheimer's disease who have MMSE between 5 and 26, who had significant delusions, hallucinations, aggression, and agitation that developed after the dementia onset, and the symptoms were severe enough that disrupt their functioning, and they needed antipsychotics. So those were the inclusion criteria. For the exclusion criteria, they excluded patients that had primary psychotic disorders such as schizophrenia or bipolar. And the primary outcome was to look at the time from the initial treatment to discontinuation of treatment. So the thought behind that is that if the patient stopped the drug earlier due to lack of efficacy, and the drug doesn't work as well, if the patient stay in the drug longer, then they perceive that as longer efficacy for that drug. For secondary outcome was to look at the change in the symptoms and looking at the score that they set in the clinical trial. So here are the results. So the mean time to discontinuation due to lack of efficacy favor olanzapine and risperidone compared to quetiapine and placebo. So the patient in the placebo group took the drug for about 9 weeks and realized, oh, it's not helping me, so I'm going to stop it. And then in the quetiapine group, patients took it for 9.1 weeks, which is not much more than placebo. However, for olanzapine group, they took it longer, up into 22 weeks, and then risperidone, a patient took it up into 26 weeks. For the secondary outcome, there was no significant difference in improvement in the global change. However, when we look at the improvement in, look at the numbers, 32% in the olanzapine group, risperidone 29%, quetiapine 26%, placebo 21%. So there's some improvement, but not much more compared to the placebo. So the median time to discontinuation due to side effects favor placebo, because placebo people they don't feel the side effect. But people who were on the olanzapine, quetiapine, risperidone had more side effects. There were higher rate of Parkinsonism and EPS in the olanzapine group and risperidone group, and compared to quetiapine and placebo group. So as you can see, EPS is 1% here per year for placebo, and quetiapine is 2%. So quetiapine has less EPS side effects. There were more cognitive disturbances and psychotic symptoms in the olanzapine group, and also with other medications compared to placebo. Body weight and BMI increased with antipsychotics about 0.4 to 1 pound per month, with the most with olanzapine, and then risperidone, and quetiapine, and then placebo. So the conclusion for this study is that typical antipsychotic drugs were more effective than placebo. However, adverse effects may limit the overall effectiveness. The usage may be restricted to patients who have few or no side effects and for whom benefits are demonstrated. So therefore, clinicians and patients and family members must consider both risk and benefits in order to optimize drug therapy and patients' care. So I have the link there. So if we need to use an antipsychotic, here's the dosage. We only start out with low dose, olanzapine 2.5 milligrams daily, and then titrate up to 5 milligrams BID. However, if we keep the dose under 5 milligrams, there would be less EPS side effects. Quetiapine, again, start with a lower dose and then titrate up to 75 milligrams twice a day. Risperidone, higher dose, are associated with increased side effects such as drug-induced Parkinsonism, and also risperidone should not be used in patients with dementia of Lewy body. Clozapine has conflicting results for MPS treatment. However, it does have an off-label use for agitation and aggression and psychosis associated with dementia. But because clozapine has a lot of side effects, including severe neutropenia, therefore patients taking clozapine has to be enrolled in the RAMS program. So how about other antipsychotics? We have aripiprazole, and the brand name for that is Abilify. Aripiprazole works as a partial agonist with D2 receptors. In a simple term, that just means theoretically it's supposed to cause less movement disorder side effects, such as EPS. So this study enrolled psychosis nursing home patients. They enrolled patients with Alzheimer's disease aged between 55 and 95 years old with psychotic symptoms, hallucinations, and delusions. The primary outcome was to use the mean change from the baseline to week number 10 to look at the psychosis symptoms. The secondary symptoms to look at the mean change from baseline, but the secondary is to look at agitation and look at depression symptoms. And the result was that in regard to psychosis score, there were no improvement in the treatment group, Abilify, or aripiprazole compared to placebo group. However, when we look at the secondary outcome, there was significant improvements in the agitation and also depression score. So in this case, it didn't help with psychosis, but the medication helped with agitation. In regard to adverse effects were similar in both groups, except for mild to moderate somnolence in aripiprazole 14% and placebo is only 4%. However, when we look at the EPS incidence here, it only occurred 5% in the aripiprazole group and 4% in placebo group. So maybe working through that D2 receptors, it can help decrease the EPS symptoms. So the conclusion for aripiprazole study is that there was no benefit in psychotic symptoms. However, there are improvements in psychological behavioral symptoms, including agitation, anxiety, and depression. And also there were low PS incidences with the aripiprazole group. So as of now, aripiprazole has an off-label use for agitation, aggression, and psychosis associated with dementia. Also, aripiprazole has another off-label use for agitation and aggression due to other psychotic disorders such as schizophrenia, bipolar, and also substance intoxication. We have another kid on the block. We have brexpiprazole. Brand name for that is Rexulti. It is also a second generation antipsychotic. It does have an approval for schizophrenia and depression. This is the only antipsychotic that has an FDA approval for agitation associated with dementia due to Alzheimer's disease. The other antipsychotics I talked about earlier only had the off-label use. So aripiprazole and brexpiprazole share the same basic chemical structure. However, there is a chemical ring right here that's added to brexpiprazole, and this chemical ring is supposed to help the agent have more affinity to the D2 receptors. So again, theoretically, it's supposed to decrease movement disorders side effects such as EPS even more than aripiprazole. But it is hard to know because there is no comparison to compare EPS side effects with aripiprazole and brexpiprazole. However, if we look at the major depression studies, looking at akathisia is when the patient cannot sit still. Akathisia occurred about 25% in the aripiprazole group compared to placebo, and then only 9% in the brexpiprazole compared to placebo. Does it mean that brexpiprazole have less EPS compared to aripiprazole? Maybe, not sure. It's unknown really, unless we have the head-to-head study. So brexpiprazole study, it involved patients compared to placebo. It was a 12-week study, and then it enrolled patients who had Alzheimer's disease with significant agitation and aggression score. And then the primary endpoint was to measure the Cohen-Mansfield agitation inventory. So this is the assessment scale to measure agitation. And the outcome was there was significant reductions in the CMI score for the 2 milligrams and the 3 milligram doses. However, the 1 milligram did not show any improvement compared to placebo. For safety data, there were more side effects in the brexpiprazole group, including insomnia, somnolence, nasopharyngitis, and UTI. Another antipsychotic, pimavanserin, brand name is Nuplazid. It is also a typical antipsychotic. This one has no dopamine activity, so therefore it is good to use in Parkinson's patients. It has an FDA indication for treatment of hallucinations and delusions associated with Parkinson's. In the Harmony trial, they enrolled about 200 patients who had Parkinson's disease and who has psychiatric symptoms. And they used the scale for assessment of positive symptoms to assess efficacy. So looking at the efficacy data, everybody started out here. Everybody has very high psychosis symptoms, and they gave placebo and the drugs, pimavanserin, about week 2. Placebo group plateau out, maybe increased a little bit here, but however, the pimavanserin group, the psychosis symptoms tend to improve. Side effects for pimavanserin include GI side effect, nausea and constipation, peripheral edema, and also hallucination and confusion. So this is why it is important for us to know the patient's baseline, because when we give a drug, we think it's going to help hallucination, but it can actually worsen the patient's hallucinations. So it's always very important to know the patient's baseline before starting any drug or increasing the doses. So the drug manufacturer for pimavanserin tried to go after other psychosis indication, not just associated with Parkinson's disease. They wanted to go for psychosis indication due to Alzheimer's disease. However, there was not enough efficacy data, so the FDA rejected that in 2021. They did more studies, newer studies. The study 19 shows some modest benefit. However, on the neuropsychiatric inventory scales, however, that wasn't enough, so the FDA rejected again in 2022. So here's the off-label use and the indicated indication. So epiprazole Abilify has off-label use for agitation, aggression due to dementia, and also due to other psychiatric disorders. Brexpiprazole is the only antipsychotic that has an FDA indication for agitation associated with dementia due to Alzheimer's disease. Pimavanserin or Nuplazid still has an indication for psychosis due to Parkinson's disease, but not due to Alzheimer's disease. Looking at drug side effects, the one that I highlight here are the 7 that I talked about. Looking at EPS right here, epiprazole, the one that works through the D2 receptors, have less EPS, same thing with brexpiprazole. Olanzapine, it also has EPS, however, it has a lot of metabolic side effects, including lipid increase and then also weight gain. Pimavanserin has less EPS or even no EPS at all. That's why it's good to use it in Parkinson's disease. Quetiapine has less EPS. However, it does have metabolic side effects, not as much as olanzapine though. Risperidone has a lot of EPS side effects. And then clozapine has so many side effects. That's why it is on the REMS program. Looking at drug costs, most of these medications have generic, except for Rexulti or brexpiprazole. A month supply would cost about $1,500. Pimavanserin Nuplazid is another brand name. 1 month supply costs about $5,000. So that's why I haven't seen these two being used a lot because they cost so much. They are really cost prohibitive. So we all know that both typical and atypical antipsychotics may potentially increase mortality and stroke. That's why it is important for us to inform patient, caregiver, and family member the potential risk, and then we document that in the patient's chart. The American Psychiatric Association recommends that if a risk-benefit assessment favors the use of an antipsychotic for behavioral and psychological symptoms in patients with dementia, and treatment should be initiated at a low dose to be titrated up to a minimum effective dose. In patients without any clinical significant response at all after 4-week supply, and it's time to taper and withdraw the therapy. However, if patients respond to the medication, then the American Psychiatric Association recommends to keep the patient at the minimum effective dose, but we need to attempt to taper and withdraw the drug therapy within about 3 months starting the drug. That's when we want to talk about should we continue medication, taper off, or discontinue medication? And the use of antipsychotic medications should only continue if the medication provides benefit. And discontinual of antipsychotics should only be considered or should be considered on a regular basis while assessing the risk of relapse when the patient stops the medication and the risk of side effects if the patient stays on the medication. And keep in mind that some patients may not be able to taper off because of relapse risk, especially patients with severe baseline symptoms. They may be at high risk for relapse when we discontinue the medication. So we just finished talking about the typical antipsychotics. So let's move on to antidepressants. A lot of data actually favors citalopram, and I can go through that. The clinical trial called CITE-AD is to assess the effect of citalopram on agitation in Alzheimer's disease. It was a randomized placebo-controlled trial. They enrolled patients with probable Alzheimer's disease with an MMSE score between 5 and 28. However, these patients have significant agitation. They randomized patients to receive citalopram 10 milligrams to start out and then taper up to 30 milligrams, and then compare that to placebo. The primary outcome was to measure the agitation. So by using a variety of agitation assessment scales. The secondary is to use other agitation scores, including the CMI score here, and also ADL, and also caregiver distress. And the results, so citalopram has significant improvement in regard to decreasing agitation compared to placebo. That was the primary outcome. For secondary outcome, the CMI score, which is agitation score, that patient had less agitation and also less caregiver distress. So there was a significant improvement in that area. The subscale agitation or ADL, there was really not that much difference. Adverse side effects occur more with citalopram, such as worsening of cognition. Again, we need to know the patient's baseline before starting the drug. And also there were more QT prolongation with citalopram. So how about escitalopram? Escitalopram is the S enantiomer of citalopram. So that S enantiomer allows the drug to have more selectivity for the serotonin reuptake inhibitions. That basically allows serotonin to be more available in the CNS. So there is another study called S-CITAT, which is the study for S-citalopram or S enantiomer of citalopram, which is S-citalopram. It is to evaluate the safety and efficacy of S-citalopram. And actually, this study is funded by the National Institute of Aging because of the positive finding of the citalopram. Therefore, now the National Institute of Aging is funding this study for S-citalopram. It's going to use the same primary outcome, just like citalopram. This study is looking for participants and to enroll patients to give citalopram and titrated that to 50 milligrams a day compared to placebo. And the primary outcome is to use the same agitation and depression scales. And right now that study is currently enrolling patients. So we don't have the result yet. So hopefully soon. So stay tuned. How about other antidepressants? So this is a systematic review and network meta-analysis here, looking at any randomized control trial that use antidepressants to treat agitation in dementia patients. So they pulled in 12 articles with over 1,100 patients. The efficacy was to use a CMI scale, and if CMI scale was not available, they used other agitation assessment scale. And the results are that all these randomized trials, they used antidepressants compared to placebo. There was no head-to-head comparison. There was no study compare one antidepressant against another. So the result also show again, citalopram has significant efficacy compared to placebo. And how about other antidepressants? There was no significant effect for sertraline, mirtazapine, trazodone, and fluoxetine compared to placebo. And this systematic review used a formula. It's called the area under the surface of the cumulative ranking curve. It's called SUCRA. SUCRA was used to express the efficacy and safety ranking of various treatment. So it used this formulation to rank efficacy and also safety data. So according to this efficacy ranking by SUCRA, citalopram ranks the highest in regard to helping with agitation compared to placebo. So 94% for citalopram, sertraline 53%, mirtazapine 46%, placebo 40%. However, trazodone and fluoxetine is worse than placebo. For this review, they said that the efficacy data was for acid citalopram was not available. In regard to adverse events, trazodone has the highest side effect of all. And the most common side effects were dizziness, tremors, and weakness. And also SUCRA formula, they calculate out the probability of adverse events ranking from highest to lowest. So it ranked trazodone has the highest side effects, and then sertraline, then mirtazapine, and citalopram at 41%, and placebo 40%, which is not that much more than placebo. So this shows that citalopram has high efficacy and low side effects compared to placebo. Escitalopram, interestingly, is less than placebo, but the study investigator thinks that the number is low is probably due to small number of participants in the study. So the conclusion for this study here is that citalopram is probably the effective antidepressants for the treatment of agitation symptoms in patients with dementia. There's some limitations for all clinical trials, and this one, because it has smaller number of participants in the trials, and also the study design, they use different assessment scale. However, it does show that citalopram does have high efficacy compared to placebo. Something to keep in mind is that fluoxetine has a very long half-life, like 9 days, and has a lot of drug interactions compared to other SSRI. So therefore, it is less desirable for older adults. Paroxetine has the most anticholinergic side effects. It can affect cognition. Bupropion, venlafaxine, and other SNRI have not been well studied in Alzheimer's disease. Tricyclic antidepressants has a lot of anticholinergic side effects, so therefore we don't want to use it for NPS. Plus, they're not as well as tolerated as SSRI, so therefore we should avoid tricyclic antidepressants for NPS. So as of now, citalopram does have an off-label use for aggressive or agitated behavior associated with dementia. So we always want to start out with a lower dose, 10 milligrams a day, and increase it to 20 milligrams a day after about 3 days or 7 days or so. And then for adults younger than 60 years old, if symptoms are not improving, the dose can be titrated up to 30 milligrams a day, maximum dose. However, for adults who are older than 60 years old, then we want to keep the maximum dose, 20 milligrams a day, due to risk of QT prolongation. It's also important to do an EKG at baseline for patients who are at high risk for QT prolongation due to certain medical condition or due to certain medications that they're on. And also Besides checking sodium due to hyponatremia associated with SSRI, we also want to check potassium and magnesium because when potassium and magnesium are abnormal, that can also increase the risk of prolongation. So we've just finished talking about antipsychotics and antidepressants. So let's move on to other medications. Dextromethorphan. Dextromethorphan combination product. So I'm talking about the cough medication, dextromethorphan that are in the cough and cold product. Dextromethorphan is a cough suppressant. When using for coughing, the dose can be used up to 120 milligrams a day. However, when used in agitation, it's much lower dose, 20 milligrams to 45 milligrams a day, in combination with quinidine or bupropion. So dextromethorphan is thought to work through the glutamate modulation pathway. It works by inhibiting the presynaptic glutamase release, and it also works as postsynaptic to modify the glutamate response. So by doing this, it's supposed to help with agitation or decrease agitation. So dextromethorphan is combined with quinidine or bupropion, and bupropion and quinidine is basically to prevent the breakdown of dextromethorphan, making or increasing dextromethorphan more available in the CNS. Dextromethorphan, when combined with quinidine, is under the brand name called Nuedexta. It was approved in 2010 for the treatment of pseudoboba effect. That's for people who laugh a lot or who cry a lot for no apparent reason. And that's due to their brain injury. It does have an off-label use for agitation, aggression in Alzheimer's disease. Dextromethorphan, when combined with bupropion under the name of Auvelity, it is approved for the treatment of a major depression disorder. So for Nuedexta, the study was to enroll patients with Alzheimer's disease with significant agitation. They enrolled patients between 90 to 50 years old who has Alzheimer's with significant agitation score. And the result turned out to be that dextromethorphan and quinidine show greater numeric reduction in the agitation and aggression domains by week 5. And the dose that we use is to start out low once daily for 7 days and then increase it to twice daily. Side effects are GI dizziness, edema, UTI, and also QT prolongation because of the quinidine. So it's important to check for drug interactions when we start this medication, especially when patients are on cardiac medications or other psychiatric medications. So therefore, we do need to have an EKG at baseline to assess for QT intervals. And also, we want to check to make sure potassium and magnesium are normal before starting the drug. When dextromethorphan is combined with bupropion, it is under the name called Auvelity. In the ADVANCE-1 study, it involved patients with Alzheimer's disease with agitation, and patients would be between 65 to 90 years old who had significant agitation. And the primary outcome was to use a change in the CMAI score. So again, that's the change in the agitation symptoms. And after week 5, dextromethorphan and bupropion significantly reduced the CMAI score, meaning helping agitation in Alzheimer's disease patients. And because of these positive findings, this drug was granted breakthrough therapy designation for the treatment of Alzheimer's disease agitation in 2020. After that, there was another study called the ACCORD study. It shows that clinicians reported agitation improvement compared to baseline. Care partners also reported improvement in agitation. And also care partner distress and burden, quality of life, and also depressive symptoms were improved compared to baseline. So we have the advanced one study, we have a core study, and now we have the adverse effect would occur more in the ibuprofen dextromethorphan group compared to the placebo group. And results with the side effects was mostly GI and dizziness. Now we have the advanced 2 study for the same drug because the advanced 1 study showed positive result and it was granted the breakthrough therapy designation. So there is an advanced 2 study now. Is looking to enroll patients right now using the same CMAX score. They aim to recruit more patients, 350 patients, and then the study is anticipated to conclude in June 2025. So we probably don't hear about the result until maybe beginning of 2026. So here it is, Nuedexta has an off-label use for agitation aggression in Alzheimer's disease. It does have an indication for pseudobulbar effect. Look at the cost, almost $1,000 a month. For the dextromethorphan and bupropion, it still has an indication for major depression. However, we're looking forward for that study to be done next year in June. And then the cost is about $600 a month. How about prazosin? So about 2 years ago, exactly 2 years ago, I gave the talk and I talked about the PEACE-AT trial. And that's the trial to look at prazosin disruptive agitation in Alzheimer's disease. And at that time, they were still enrolling patients. We didn't have the result yet. Prazosin, as of now, has an FDA approval for hypertension only, and it's not first-line therapy. It's for resistant hypertension. It does have an off-label use for post-traumatic stress disorder related to nightmares and sleep disruption. So the PEACE-AD trial was to enroll patients to give them prazosin compared to placebo. Unfortunately, with COVID, it only enrolled very low number of participants, only 35 participants. And they enroll patients to receive prazosin titrate up to 4 milligrams in the morning and then 6 milligrams in the evening compared to placebo. And they look at the agitation score. And the result after 12 weeks was that there was no difference between prazosin and placebo in regard to agitation. However, looking at the CMAI score again, another agitation score compared to placebo, there was some significant benefits, and that's basically indicating maybe there's some potential efficacy, and hopefully there will be another study in the future to enroll more patients. This time, the patient, there was just not enough for a very small number of patients. Because prazosin can affect blood pressure, so therefore they looked at the cardiovascular events in the study also. So there was really no significance in the vital signs compared to the placebo group. However, there were a lot of side effects for prazosin, including dizziness, syncope, somnolence, and dizziness as well, especially postural dizziness. So as of now, prazosin does not have an off-label use for agitation due to dementia. So how about cholinesterase inhibitors and memantine? According to the 2015 systematic review and meta-analysis, looking at 15 randomized control trials, it shows that cholinesterase inhibitors have shown a small efficacy for NPS in mild to moderate dementia, and not for severe dementia. However, patients with dementia of Lewy body may have more beneficial response. For memantine, post-hoc analysis show that patients on memantine have reduced agitation and aggression. However, later systematic reviews show that the studies have not demonstrated that memantine is effective for MPS of dementia. So we have patients who take cholinesterase inhibitors. At some point, there's really no perceived benefit. Then it's time to discuss tapering and go off. So this is a tapering schedule here. As always, we want to avoid abrupt discontinuation unless the patient has severe side effects. But if we want to taper using the 50% dose to reduction every 4 weeks prior to discontinuation. And then this is for dementia. When we stop cholinesterase inhibitors, if we see that conditions are worsening after withdrawal, it is okay to reinitiate a cholinesterase inhibitor. So how about anticonvulsants? We heard about lamotrigine. So this is a retrospective medical record review in 2008, looking at patients who had manic symptoms and agitations in older adults with dementia. Look at the number. This review was only 5 patients, so very small. So the review showed that clinicians started lamotrigine based on symptoms and based on patients failed to respond to typical antipsychotics. Patients received lamotrigine between 100 milligrams to 300 milligrams a day for 5 months. And the outcome was to measure the MMSE score, depression score, and also mania score. And the results shows that there was no significant change in MMSE score, no significant change in the depression score. However, there was some significant change in the mania rating scale. Of course, there's some limitations, smaller sample size, and also the YMRS, which is the mania rating scale that's used for bipolar disorder, but not the agitation scale. So therefore, not so sure if lamotrigine would be applicable for use in agitation in patients. So there's another case study for lamotrigine. This patient had frontal lobe dementia who had a lot of aggression. She tried everything. She tried antidepressant, antipsychotics, bisphoron, benzo, Depakote with no improvement. And then she was treated with lamotrigine, started out with 12.5 milligrams a day, titrated up to 100 milligrams a day within 4 weeks. And then at that dose, she stayed on that dose for 6 months. And then she did not have any relapse. She had no side effects. That's one case study for lamotrigine. So as of now, there's no big randomized trial for lamotrigine regarding its potential efficacy in controlling psychotic symptoms in dementia. One thing to keep in mind about lamotrigine is that it can cause severe skin hypersensitivity reaction. Some may be mild skin rash, but it also can cause severe life-threatening skin hypersensitivity reactions, including Stevens-Johnson syndrome, and then also TAN, and also the DRAS symptoms. And the lamotrigine-induced skin eruption generally occur between 5 days and 8 weeks after starting lamotrigine. So therefore, it is very important to start lamotrigine at a lower dose and titrate that up to avoid severe skin hypersensitive reaction. So if patients miss lamotrigine for more than 3 days, some experts, they want to start the medication again at a lower dose. So if the patient is on 300 milligrams a day and miss for a week, we're not going to have the patient restart lamotrigine at the same dose. We're going to restart the patient at a lower dose to avoid that severe skin reaction. So I heard that we had one case study. The patient said that I could not, the patient said I cannot go off of lamotrigine. I wonder if the patient misunderstood. Maybe that the patient cannot miss a medication instead of cannot go off of the medications. But it is okay to go off lamotrigine. But if the patient missed the medications for several days, it's important to restart at a lower dose. How about other anticonvulsants? Depakote, carbamazepine or Tegretol. There's not enough evidence for benefits for carbamazepine to recommend its use for MPS. And how about Depakote? Several earlier reports show some improvement in aggression. However, subsequent systematic review shows that Depakote was ineffective for MPS treatment. There was one study, open label perspective, showing gabapentin having little benefit for MPS. However, patients who have neuropathic pain, such as postherpetic neuropathic pain or other neuropathic pain, gabapentin can help with pain and also can help with agitation associated with the pain. Drugs that we want to avoid, benzo. So benzo should be limited to only brief or stressful events, such as when the patient changed their residence. They get a lot of agitation when they change their residence, and also should be used for any anxiety-provoking medical events. If we need to use benzodiazepine, we want to use a shorter half-life benzo, such as lorazepam. We want to avoid older antihistamine because of anticholinergic side effects. We also want to avoid other sedatives due to sedation, fall risk, and also worsening conditions. So in summary, for NPS treatment, we always want to assess for any underlying causes for cognitive changes and for NPS symptoms. Non-pharmacological approach is always first line. When that fails, then drug therapy is recommended. And the use of drug therapy should only continue if the medication provides benefit. As always, ongoing monitoring and benefits versus harms must be done on a regular basis. With that, thank you for your attention. Now I'd be happy to answer your questions. Sorry, my slides froze a little bit there.
No problem. Trang, thank you so much. You have synthesized a tremendous amount of information with practical, pragmatic, recommendations, and just really lovely interface with so many of the comorbidities that accompany these diseases. So thank you so much. I'm sure there's plenty of questions and plenty of time for discussion.
Former President,
let's see, I see some hands up. How about, I saw Julie's hand up first.
Hi, yes, thank you so much. That was such a wealth of information. I guess my question is, with a lot of these studies, they do more global assessment scales and then in clinical practice, it feels like as a clinician, one has a go-to for certain symptoms. Do you think there will be a time when there will be more studies that are maybe targeted to more specific than like just global NPS? Or would you say that there are resources for us to understand how to use these medications a little more fine-tuned? If that question makes sense.
Yeah, I think it's they use different assessment scale, and they want to try to keep everything to cover all area from ADL to, so they want to cover, so a lot of these assessment or inputs from the providers and also from patient caregivers. So they try to capture all of that. So they have to have some kind of some scale in order and have a number to rank. They need to keep comparing apple to apple. So yes, it may be that it's not because it's a global scale, but I think in general terms, they compare that to placebo. So there's perceivement, if there's a change in symptoms, that's the score is checked. So it's compared to placebo. So if there's some improvement, they have a calculation that they have to do. All studies, they do that. So just because the study shows that the medication works in the study, however, if we try it on patients in real life, patient may have side effects, or patient may have lots of improvement. So we don't know until we try the medication, but at least there's the data behind it that there's some efficacy and we know the side effects, which one has least side effect. So maybe go with that first. I would say the approach that you use, the ones that has the least side effect, have some efficacy data around behind it, and then try it.
Right.
And then assess it. And if it doesn't help, then move on to the next one.
Right, because I think I try to tailor what I prescribe based on if someone's a little more anxious, unless I might go more with the SSRI. But I would say that just recently, a couple weeks ago, I did have a patient who was more on the anxious, agitated side, and it seemed more urgent. But she was on sertraline, and I increased the dose. And part of me was hoping that it would be enough to improve her symptoms fast, because there's a lot of urgency from her caregivers. And I'll say that it did work to increase that SSRI without having to do sedatives or do an antipsychotic. So it's reassuring to see that this SRI study showed improvement over 3 weeks. It's actually maybe faster than we might expect based on expectations of antidepressants. Yeah.
Thank you for sharing that. I'm glad to hear that it's working.
Jeff in Yakima.
Thank you, Trang. I just wanted to comment on the brexpiprazole, because I sit on Kaiser's P&T committee and we discussed this last week, and we chose not to approve it. The data was underwhelming. On the 200-point scale CMAI, the approved dose of 3 milligrams had a score difference of less than 6. So it really wasn't impressive at all, especially for a $1,500 cost. So I guess I haven't. I certainly wasn't impressed, and we were surprised that it got approved with such a minimal improvement. In fact, the FDA made them go back after the 1 and 2 milligram doses and wasn't going to approve it at that. So I just wanted to add that comment.
Thank you.
Yeah, the difference between statistical significance versus clinical significance with the way these studies are done sometimes. Anne, up in Bellingham, I think.
Hello, thank you for the talk. That was really great. My question is about sleep aids. I'm wondering, is there any recent evidence on melatonin, Ramelteon? I've also gotten some questions recently about the orexin antagonists for early stage dementia patients. I'm just wondering kind of where things stand on that.
So melatonin is still safe for patients. It's just that we wanted to have a patient take it an hour, at least a couple hours before bedtime, because it takes a while for it to kick in. And then the REMer, so it depends on the patient. If the patient has depression or weight gain, then mirtazapine would be the appropriate choice. However, trazodone at low dose can help with sleep aid as well. The other medications with a new drug class, I find I haven't seen it being used much, just because it costs so much. We have a sleep a specialist at our facility, and even that they don't prescribe as much either, just because they're not able to get it through the insurance company.
Okay, that's helpful. Thank you. I had one patient's family who was interested in it, and I was looking up to see if I could find any information. It sounded like the risks of falls was pretty significant. So I actually suggested that they not try it. But it looks very expensive as well.
Yes.
So thank you. That's helpful.
Yeah, and I just put in the chat, back in October, we had a fantastic didactic by Dr. Lena Fine around sleep and dementia, and she dove into some of these very issues. So I put the link to that. It's on our website too, and some resources.
Great, thanks.
Yeah, absolutely. And then I saw, Yelim, I don't know if your answer was, or your question was answered or your hand went down, but. Oh, can't hear you. You look to be unmuted, but perhaps your microphone is muted. Still nothing. Oh, no. Maybe you can throw it in the chat if we can't hear you. All right, try that. And then Reza, I see your hand up.
Hi. Actually, my question is about the safety of the antipsychotic in patients who have seizure disorder. So I had a couple of patients, they were in Seroquel, they was seen by neurologists and then had a seizure, basically, they blame Seroquel. So if there is anything about seizure and antipsychotic, they decrease the threshold of the seizure. Which one of them is safest in these patients? Next question is that how about we ask the patient to take a low dose of dextromethorphan and bupropion, for example. Is that instead of just mixing them? Thank you.
I'm sorry, what was the second question?
How about if we ask the patient to take dextromethorphan and bupropion separately, just instead of having it in one combination, you can ask them that, okay, low dose of, calculate the low dose of bupropion, for example. I'm not sure if it's available or not, like a liquid form, but for dextromethorphan, we can get it over the counter, as you said.
That's a very interesting question. I thought about that too. I said, cough medication is very cheap. But the way they make the medication is they make it extended release. Formulation is used once a day. It's supposed to release the drug slowly, so it can last for a whole day. And also the bupropion is supposed to help the breakdown of the medications. So I don't know the answer to that really. I really don't know how, because if I don't know if the medication still stay longer in the CNS for it to work. So I don't have the answer for that question. So sorry. Maybe there should be a study for that.
Any thoughts on the first part of the question around lowering seizure threshold with antipsychotics?
I think the the main idea we always want to start with a lower dose and then go up the dose. So I would say that's basically the best approach is to start low and go slow for not just seizures risk for any medications or side effects.
Great, very good. And Karen Hayes.
Yeah, hi everybody. As a caregiver representative for Echo Dementia, I encountered with my husband who had a presumptive Lewy body diagnosis. They put a whole bunch of stuff on his allergies, which I wish EMR could get more specific. There's allergies, and then there's drugs that are not tolerated, and then there's drugs that are contraindicated. But it's everything goes under allergies. So what happens is allergies becomes the heuristic, and people think they can't give. So having a Lewy body diagnosis, there was, Haldol and all related kind of antipsychotics. All the anticholinergics, etc., were on his allergies list. So when he did a sudden zoom into, psychotic behaviors and ended up hospitalized and in geropsych, I can't tell you how many times as the caregiver I had to keep going over this, that he's not really allergic to them. And, risk benefit has changed. And, if he needs a dose of Haldol because he's attacking his caregivers, then you can do it. But it's, and so then I'd sit down with the pharmacist, the head of the hospital, and get it all figured out. And then boom, it's back up on the allergy list again. And then when he went back to his long-term care facility, then they wouldn't give any of the meds that the hospice had ordered because they were on his allergies list. And so it took, there were a lot of different systems working and not working together. And so finally the neurologist that had put them on the allergy list was able to take them off and write a letter that I could then photocopy and hand to people to say, these are not really allergies. It was just precaution, risk benefit has changed, blah, blah, blah. So all that is to say, when you do prescribe these medications, if the family has been told, don't give these to your loved one with dementia, because it could put them into delirium or some kind of terrible thing might happen. It might take some education on your behalf, or consulting with and talking to the original person that put them on the allergies list and try and get those stripped off. Just because the dementia has now gone into another phase and we need access to all of these things that Trang was just talking about. And I think my husband got delayed care because, and I have a doctorate degree in nursing. And so I'm really comfortable with, talking with people in healthcare and so forth, but most caregivers aren't. So just kind of thinking about those kinds of systems issues and EMR issues and caregiver and family education about when these medications are starting to need to be diagnosed or given for severe diagnoses.
Yeah,
I don't know,
really.
Frank, do you have anything to add to that?
Yeah, our psychiatrists great about documenting, and they have a section in their chart, and it says medication tried and failed, and they list all the medications, mirtazapines, increased sedation, or anything. They list that down, but they don't put it on allergy, and they copy that section forward for every single visit. And I like primary care providers to do that as well, but it's not happening. So I know exactly what you're talking about. Yeah, it's not everyone is on the same board. Yeah, I wish everyone could have that allergy section, not allergy, but medication try and fail, because it's so important to when we describe an expensive drug, and the insurance company wants what were the other medications that have been tried and failed. And then at least we have that. It's easy to go back, okay, patient try this, fail this, and then boom, 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 boom. It's easier to get the new expensive, the more expensive medication covered when we do a prior. So I totally agree with you about having that section in the chart and have copy that forward instead of on the patient's alley.
Very good. Another excellent kind of pragmatic piece of advice. I'm wondering, we only have a couple of minutes, but I'm wondering if anybody in our community has any tips or scripts that they use when they talk about that, our goal is to avoid these medications, but there may, or, I don't know, it will, but may come a time where we need to revisit that. How do you talk to families or people with memory loss? How do you counsel them?
I can tell you what I say. I always tell them, look, I'm adding this in the allergy list, and it's unfortunately the way that our charts work. There isn't a be careful list, but I always specify not an allergy, potential reaction, so that it populates into the note. And I try to say, we want to avoid this and we'll try other medications first. But I've had cases in which I've had to use it, and I use the phrase, if we've pushed against a wall, such as the situation where it's really unsafe for the person to be having certain behaviors. And so you choose the lesser evil and you monitor it closely. And most of them are okay with it. But it's challenging, I do realize.
Well, perfect example, though, of kind of how to phrase that, and the importance of continuing to revisit that conversation over time. So,
Chris,
good.
This is Mimi. If I could just
Yeah,
add
please.
quickly. We often use this phrase for not just talking about these medications, but for other circumstances too, and using the phrase, we're in a different place now. And we have found that effective. I have in my practice, but just we're in a different place now, followed by silence.
Yeah, that's pretty perfect. And I would guess also validates what the family feels too, right? They know they're in a different place. So very good. All right. Well, I am going to just for 1 second share my screen because I've heard from the good Dr. Eisenberg that this actually worked. So if you are a UW faculty, staff, or student, this again is the process to obtain CME. We'll send that out to you also, but I think you only have a couple hours pre or post session to log that. So there you go. There's that. And then I think that's what we've got. Our next session will be Friday, April 12th with our own Mary Grace Becker here at Memory and Brain Wellness and the director of the Memory Hub, talking about community resources for dementia patients and families. Although I think she would rephrase that to people living with dementia and their families. So, all right. So we will hopefully see you then. Thank you for your